nervousness, speech is part of that. My orientation.
Muscle.
What'd you say?
Muscle.
Yeah. What about problem solving? Is that part of it?
Oh, yes.
What about motor skills, your fine motor skills, things like that? Okay, so y'all had anatomy. I don't have time to teach you anatomy. Y'all had 8 hours of anatomy already, okay? So I did put these slides in here just to kind of remind you of the central nervous system, what we're talking about. The central nervous system is your brain and your spinal cord. Then your peripheral nervous system is all the stuff to the extremities and the organs and things like that. What's the difference between sympathetic and parasympathetic? Which one's sympathetic?
Arousing.
Yes, that is your fight or flight, okay? And you need to know the difference between the two of those. And they're on this thing. You don't have to really think too hard or write much down. I gave you the PowerPoint. I even made it so you could type on the bottom if you want to. Central nervous system, we're going to talk about in the whole course, level 2, 3, and 4. We're actually going to talk about the brain. We have some eye disorders, some ear disorders. I'm going to tell you in here, because I know you don't read, I'm going to tell you in here exactly what to focus on. Because if you told me I had to read a whole chapter about head injuries and it had 17 pages about strokes, I'd be like, nope, not reading that. It's not on my list. So I tried to limit down your pages that you can go back and refer to if you need to, and I put them in the slide so you'll be able to see them. But we're going to talk about neurotransmitters in here. We're going to spend a whole 6 hours talking about hormones later in the semester. But this is just a review slide. So cognition, intelligence, problem solving, memory, your attention span, all of those things we talk about in cognition. We're going to talk about alterations in cognition, whether that be from a brain tumor or from plaque in the brain on a person who has multiple sclerosis, whether it is the dementia that comes with Parkinson's disease. So we're going to talk about all those. Head injuries. If I have a frontal lobe head injury, I'm going to have some memory loss and maybe some changes in my personality. We'll talk about all of those. Mobility. We're going to talk about mobility, not like we did yesterday, but to the extent that if I have an injury, either a mechanical or a chemical, which would be your neurotransmitters, I have this cycle. I have pain, I may have some poor balance, some lack of coordination, decreased muscle strength, and the less I move, and the problem becomes worse. So we're going to talk about the disorders that affect movement and mobility in your patients. We're going to talk about sensation in level 3, but I just put them up here because we are going to talk about swallowing. Swallowing is a big issue because what's our risk? You can't swallow. Aspiration. And it affects a lot of the disorders we're going to talk about. We're going to talk about sight and vision in level 3. We're going to talk about hearing in level 3. We're never going to talk about the sense of smell, just going to tell you. Nobody cares. That's not true, Miss Cooper cares. And we're going to talk about touch and feeling because of the sensation, especially when patients are walking or you hand the person with Parkinson's disease his pills. Where are all the pills?
Everywhere.
All over the floor or all over the bed. So we're going to talk about sensation in that regard as to what you need to be thinking about when you're taking care of a patient with any one of these disorders. Here's the big thing you need to be thinking about. On everything we talk about, you need to be thinking about client safety. First of all, what do I need to teach this person safety-wise? Is it to do with medications? Is it to do with my Parkinson's patient who walks like this and his wife likes throw rugs? Is that a problem?
Yes.
Yeah. So what do I need to teach my patient to keep them safe? Second of all, how am I going to prevent injury? I have no sensation in my feet because, I'm a diabetic and I want to soak my feet in hot water. You need to teach them you can't do that. So what are you going to teach them to prevent injury? Aspiration prevention is a big one because a lot of our disorders we're going to talk about today have to do with the inability to swallow. And so if we aspirate and we're not breathing, that's a problem. Fall prevention is huge in the hospitals. well, everywhere really, but in the hospitals, there is so much paperwork to do if your patient falls. So we need to take all the precautions we can to keep that patient from being on the floor. Does that include teaching them when they go home?
Mm-hmm.
Yes, because I just discharged them at 3 o'clock, and now at 9 p.m. they're back in the ER because they fell and broke their hip. So fall prevention is huge. We're going to talk about some medications today, the glucocorticoids in particular. Well, we'll probably get to them tomorrow. But you know, if somebody's on prednisone forever, what's their risk of infection? So you need to teach them some things, and you also need to protect them from you if you're in the hospital. And we're going to talk about those when we talk about those drugs. And then with all of the disorders, there's the potential for complications. If I have a spinal cord injury and I am immobile, can you think of 2 complications off the top of your head? Bed sores, skin breakdown, pneumonia. So we want to prevent any complications from occurring that we can prevent from occurring. So we're going to talk about at-risk populations. So if you're looking at this, all populations are at risk for any of these things. There's a few that are autoimmune, but for the most part, anybody could have an accident and have one of these disorders. Parkinson's disease, although there's a familial tendency, there's nothing you can do to prevent it. So anybody's potentially at risk. Individual factors, think about that. What about my little kids? What are they at risk for? Choking hazards. What else? Falls. Head injuries. So what about my teenagers? They're at risk for everything because they're just
Everything, yeah.
They're the biggest sports injury category. They're the biggest car accident category. So they're at risk for spinal cord injuries, head injuries, chronic back injuries, things like that. So you have to look at your population group. What about old people? What are they at risk for?
Everything.
Falls in particular. The other thing that they're at big risk for if you don't do good teaching is polypharmacy stuff, where they go to this doctor and get medicine for this condition, and they go over here and get medicine for this condition, and all these doctors don't know the whole picture, and so they're at big risk for drug interactions and things like that. So you have to look at when you're looking at your question on the test and on your NCLEX, look at the age group I'm talking about. Am I talking about a dumb teenager? Am I talking about an old person who fell off a ladder, who shouldn't be on the ladder in the first place? So kind of think where they fall in that human growth and development range. Okay, primary prevention means I want to stop this accident before it happens. So if I have a 7-year-old who's learning to ride a bike, what do they need to be doing? Wearing a helmet. Because I want them to protect their head in case they wreck the bike, because inevitably sometime they're going to wreck the bike. What about the stupid boy who's driving the car? Seat belts. Texting on your cell phone, things that you need to teach them to prevent injury. What about the old person? Falls. You need to teach them. You don't need to be climbing up on the ladder. I'm sorry, I know you like throw rugs, but your husband can't lift his feet more than 1/4 of an inch, so they got to go. So there's all kinds of things that you need to teach them based on what's going on to prevent it from happening. Secondary prevention means it's already happened, but what am I going to do to have this person have the best quality of life they can have? I can't prevent the accident, it already happened. I can't prevent the disease, it already happened. But what things can I teach this person, or what medications can this person take that are going to increase their quality of life? Then tertiary prevention is, I have my spinal cord injury, I've taught his family things, but now I'm trying to prevent the devastation of the illness. I'm getting them resources, I'm getting them the equipment that they need in their home. I'm working to help them with the things they need because they're going to have to live with this. So I'm doing what I need to do to make this a little more bearable.
So more like long-term health care? Okay.
You need to know this. I'm just going to tell you right now. If I put a box or a page number for you to look at on one of these slides, you better go look at it. Because I promise you, I already know what the test questions are. Okay? You need to know normal aging disabilities with cognition and mobility. And that's where they are. They're on chart 41.1 in your book. And I went through and updated these, so hopefully the pages are all right. But you got to know the difference. What is normal for someone who's older and what is not normal. They have memory changes. You think they remember what happened in 1942? You sure do, but they can't remember what they had for breakfast yesterday. You know, my dad's 82 years old. He's got long-term memory. He can tell you stories from his childhood, from his early adulthood, but he has trouble remembering where he put his keys. Well, I do too, but where he put his keys, you know. So they have some subtle memory changes. They do not have any loss of intellect, though. Just because they're slower doesn't mean that they're not every bit as intelligent as they were at one point in time. This can be caused by medication interactions, like we talked about where they go to this doctor and that doctor. And also, do these people sleep?
No.
Okay.
On and off.
They sleep on and off. They need rest, just like everybody else. But they don't go to bed and sleep for 7 or 8 hours at night. They sleep a little bit, and then they get up and wander around and watch TV, and then they take a nap during the day. So they're getting the amount of sleep they need, but they're not getting that big chunk of sleep like you get when you're younger. So they have, until you have kids, they have changes in vision. The eyes get a little bit cloudier. So let me ask you this. If I have my Cozar, which is a little football-shaped green pill, and I have my Aleve, which is a little tiny football-shaped blue pill, and I can't tell which one's which. So can you see how they can mix up their medicines and confuse them? They have decreased touch. Picking up those little tiny pills, they don't have the dexterity and the ability and sensation in their fingertips anymore. Hearing, the tympanic membrane becomes harder and doesn't move as fluidly, so they can't hear, especially really high-pitched sounds. They can't make them out.
Mm-hmm.
Did you ever notice they all have sweaters on?
They're all cold.
Yep, they're always cold. It could be 100 degrees and they're always got a sweater on. Because
So cute.
the hypothalamus isn't regulating their temperature the way it used to when they were younger. So that's a normal thing. So when you have a patient who's 80 years old and you're going in the patient's room and you're sweating to death, it's their room, and if they're comfortable, let them leave alone. I always ask them, it's kind of warm in here, are you comfortable? And they're like, oh yeah, I feel great, with 14 blankets on them. But it's their room, okay? So you have to be aware of that. So you may go from this person's room who's 100 degrees with 14 blankets to this one over here who's begging you for a fan and their room's 50 degrees. But you just got to keep that in the back of your mind, it's their room when they're in the hospital. That's why I don't do home health, because that's their home. And I can't tell them what to do there. In the hospital, I can. They move a little slower. Did you ever notice that? Yeah. My mom's pretty spry. She's 77, but she moves a little slower now. When we go somewhere, it takes a little longer to get there, get in and out of the car. They have a little bit of change in balance, especially if they've had any kind of knee or hip surgery. They're real cautious of where curbs are and how to walk. And so if you're walking with them down the hall, what do you need to be doing at the hospital?
Being right next to
You
them.
need to be right next to them. You need to have a hand on them. And I'm just going to tell you, the gait belt that you can never find, you really need to find one. They're in the bottom drawer at the nurse's station because nobody ever uses them. But if that patient goes to fall, it's easier for you to grab the gait belt than it is to jerk their shoulder out of joint. They have a little bit decreased strength. Like, I'm going to tell you, my dad's 82, he's healthy as a horse, he's strong as an ox. But in the last 2 years, I've noticed that he's got some muscle atrophy and he's not as strong as he used to be. He's slowing down a little bit. So they slow down some. Decreased response time. Why do you think they run through storefronts with their car? Because I got confused with the brake and the gas. And my responses are slower, so I didn't get my foot on the brake fast enough. So decreased response times. Decreased sensation. They can't feel as good as they used to feel, especially in their feet when they're walking. So just like the person who's looking for the ledge, they may not feel that bump in the sidewalk, and it may trip them. So you just need to be aware of that when you're walking them in the hospital. Oops. 3 things right here that you can fix pretty easy. Your patient comes in, and they're kind of confused. The first 3 things you're going to check, a blood sugar. What do you get like when your blood sugar's low?
Confused.
Confused, cranky, your mood changes. So you check their blood sugar. The second thing you're going to check is a pulse ox. Because if they're not getting oxygen to their brain, they're going to have some changes in their level of consciousness. Because, keep this in the back of your mind, this is important. Two things your brain cannot store, oxygen or glucose. It has to have a constant supply. So if there's an injury that cuts off the supply of oxygen or glucose to your brain, you're going to see some mental changes in your patient. So that's important to remember. The other thing is, and you guys learned this in fluid and electrolyte, what happens if your sodium's too high or too low? Sodium is the electrolyte that affects your brain, okay? It makes confusion, they can have seizures, different things like that. We're going to talk all about that in metabolism, but that's the one lab that you can look at to say, well, their sodium's super low, and that's why they're so confused. So just keep those in the back of your mind when you have a confused patient. What do I need to be assessing? Blood sugar, oxygenation, and labs. When your patient comes in, oh, you know what? That might not be the right chart because I might have missed the slide. You're going to do a little history on them. Who's really going to do the history with the cranial nerve tests and all that stuff? Are you as a nurse? You're not. A nurse practitioner or a doctor is. But if you're assessing a patient and you notice that this side of their face is all droopy, as a nurse, can you tell the doctor, I think something's going on because that one side of their face is real droopy. So you're not actually, as an RN, going to do the cranial nerve tests where you have them smell and all those things with the cranial nerves. You need to know which cranial nerves affects the eyes, though, which one would cause your face to droop, and particularly in here, which ones affect swallowing, which cranial nerves affect swallowing. Motor function, how are you going to test that? How do you assess motor function? Yeah, you can do that. You can walk with them, see how they do. You can have them pick up and move stuff. When you're in your patient's room, are you constantly assessing them? Yeah, you should be. We're going to talk about the Glasgow Coma scale. You don't need the Glasgow Coma scale to assess every single thing that's on that scale. Because you can say, can you turn down your television for me? And if they reach over and turn the television down, they can follow your commands. You know? So you're constantly assessing them when you go in the room. Cerebellar function, we're going to look at a picture up here with the brain. If they have a cerebellar problem, they're going to have problems with their gait and their balance. So when you stand them up and have them close their eyes, they're going to kind of tilt to one side and possibly fall over. Here's what you need to know about, though. You're going to do a rapid neuro assessment on every patient, officially or unofficially. Even if your patient doesn't have any kind of head injury or anything going on, every time you walk in the room, you're checking them for some kind of change. Because when I came in here at 8 o'clock, Mrs. Jones was talking to me. She made a lot of sense. Now I'm in here at 11 o'clock, and something's going on because her conversation isn't where it should be anymore. Or she's slurring her words. Or I can't get her to wake up. So you're constantly, every time you walk in the room, assessing your patient and the situation. You want to know if they're awake and alert and oriented. And let me look, because I think I made a note here. I think I have a page number I want you to look at. Yeah, I want you, on page 846 in your book, there's 4 terms that I want you to make sure you know the difference in those terms. And they are alert, lethargic, stuporous, and comatose. And they're in, I think they're in italics, and they're just in one little paragraph, and it tells you what the definition is. Because they're a little bit different. Okay. They're a little bit degree.
Be late for
Is
class.
that my alarm? I have my alarm set for a break, so I can think this time. I didn't get quite as far as I wanted to.
What page was it?
846. And it's just one little paragraph that defines all those terms. Because each one is a little bit more. I'm awake and alert. I'm lethargic. I'm kind of sleepy, but when I talk to you, you wake up. Who's really the lethargic patient? The one you talked about in peri-op. They just had anesthesia. So they're kind of with it, but they keep drifting back off to sleep. But if I go in there and I say, hey, I'm here, do you need anything to drink? And they wake up, they're lethargic. But each one of those is a little bit worse degree of orientation. I want to make sure they can move their arms and legs. And I also want to look at their pupil sizes for reaction, okay? See this slide right here with the red writing? This is the most important slide in all of this whole PowerPoint. And there's a lot of information in here. The very first sign that your patient is having a problem is some change in their level of consciousness. Now let me ask you a question. Does that mean I went in there and they are completely comatose? Is there anything before completely comatose?
Yeah.
Yeah, what am I looking for? Confusion. What else?
Slurred speech. You're looking for.
Slurred speech.
Any
What
joy-
about if you go in your patient's room and they are
can't remember you.
just restless? They're all over the bed. They can't settle down. You can't really pinpoint it. Restlessness is the very first sign that something's going on. But this level of consciousness change is the biggest indicator that you've got a problem. So that's why you're always, you don't just run in and say, here's your pills, and walk back out the door. First of all, I don't want her choking on her pills, so I'm going to stand there until she takes them. I don't want her roommate taking the pills. And I'm assessing her to make sure that she's still what she was a little ago. So you know when you go to the hospital and they say, well, we do walking rounds, and then they stand outside the patient's door or stand at the nurse's station to give a report? Is that walking rounds? No, walking rounds is walking right into that room and saying, good morning, Mr. Edler, how are you? I'm going to be your nurse today. And making sure that Mr. Edler is exactly like she's telling me he is before she leaves. Because when she's gone home and she's sleeping or she had a bottle of wine, she ain't coming back when Mr. Edler's cuckoo and you can't figure out what's going on. So when you're doing walking rounds, they're important for a reason. A, I'm checking to make sure my patient's safe and alive. Because you know, nothing worse than 2 hours after shift change walking in, your patient's dead, you ain't been in there yet. So walking rounds, you're checking for safety and make sure your patient's okay. And I'm making sure I'm really getting what this person's telling me I'm getting. Because you're really taking a big chance if you just trust them at the nurse's station to tell you, oh yeah, he's good, no changes from yesterday. Okay. I mean, you're taking a chance. I mean, it's your, I can go in there and as I'm looking around, I can kind of look at the IV and say, really, Terry, you're going to leave me with an IV that's bad? Did you know the IV was bad? You know, and Terry can fix the IV before Terry leaves.
Terry knew.
I know. They all know. Just telling you, they all know. Or I can go in there and Mr. Jones is laying in a poopy mess and we just cleaned him up at 6:30. Well, you got to clean him up again before you leave. So walking rounds does play a purpose. It gives you exactly what the nurse is telling you you're getting, and you have the opportunity to make sure they're breathing and in a safe environment. So really, when they tell you to do that, I know it's kind of a pain, I know, but I've been left in a lot of messes, so I always do walking rounds. Oh, can we go in there and look at them together? So they don't leave me with a mess. Here's our Glasgow Coma scale. Y'all heard of this in anatomy, I'm sure. Did you talk about this in level 1 at all? Okay.
Yeah, it was on the
So
test.
it was on what?
It was on a test.
It was on a test? Ooh, they got way ahead of
Just talking about it, yeah.
Okay. Tell me what's good about this scale.
Mm.
What's good about it?
If you click Neuro and see like what you need to do in the ER, like we use it all the time
Okay.
in the ER for like AMR calls, and they'll say, you know, GCS is 4, and then you're like, we know exactly where they're going and what we need to do for that immediately before we even hear what happened to them. So,
Okay. So yeah, it gives me a quick picture of what's going on because this is a scale that ranges from 15 to 3. Even a dead person scores a 3. Okay? Everybody gets 1 point whether they're alive or dead. So if the Glasgow Coma scale says they scored a 2 or a 0, no they didn't, because even dead people get 1s. So they get 3 total. So 15 is the maximum, 3 is the worst. So the higher the Glasgow Coma scale is, the better condition my patient's going to be in. Okay? So is this subjective or objective?
Subjective. Subjective. Because you can assign, subjective, you can assign,
Subjective because it can change. Well, he obeys commands, you can see him doing that, right?
Three people could go to three different scales.
Right. I could go in there and assess Chelsea and say, oh, well, she's at 11. And then you could go in there and you interpret something that she's doing or not doing differently, and you come out and say, no, she's a 10. And that doesn't seem like a lot of difference, but if my trend is going down instead of up, it's a difference. Okay? So it is objective in that it gives you some criteria, but it's very subjective in how you interpret it. So again, if I have a patient, particularly with a head injury, and I have Glasgow Coma scales, neuro checks ordered every 4 hours or every 2 hours or whatever, when Justin's trying to get out of there, we're going in there and we're going to do this together. So when he walks out the door and my patient's a 12, I know that we were looking at the same thing and we agreed he was a 12. Because if I go in there, he says, well, I did his Glasgow Coma scale at 6 o'clock and he scored a 12, and I go in there at 8 p.m. because, I was busy drinking my coffee, visiting with my friends, and now he scores an 8, and I call the doctor, and the doctor says, well, he's been an 8 all day. So you need to know exactly what he's assessing, and you need to be on the same page. So 2 nurses at the bedside. So the eye opening is pretty easy. Do they open their eyes when they just kind of aware that you're there? Do you have to talk to them? Do you have to actually touch them to get them to open their eyes? That's pretty easy. Best verbal response. A little bit more, they're oriented. Have you ever talked to a little old person and you think, oh wow, she's really with it? And then you talk to her for 20 minutes and you're like, gee, she's crazy as a loon. Because you talk to them and you just, is she confused? Is that her normal? You just don't know. Inappropriate words means when I'm talking to you and I say, well, can you tell me what you had for lunch today? The Lone Ranger. Their conversation's not matching me. They're inappropriate. Incomprehensible sounds is kind of garbled, mumbly speech that makes no sense at all, or just making random noises. So that's a little bit more, you have to kind of know your patient, and is that the patient's norm, or what's going on. A little more subjective in that one. The column for motor response, 6, means I went in there and said, Brittany, can you turn down your TV so I can do your assessment? And you reach over and turn down your TV. She's totally with it. She can do what I tell her to do, okay? Localizes to pain means, here's the difference between these two because everybody gets them mixed up. Localizes means I go to start someone's IV who seems to be, in an unconscious state, and they take the other hand and push me away. So somehow they've crossed the midline of their body and they're pushing me away. 5 means I go to start the IV and they just jerk their hand away. Okay? So to score a 5, they're actively pushing you away. To score a 4, they're jerking away from you with the arm that you're causing the pain on. What kind of painful stimuli could you try besides starting an IV?
What are those little things you poke in, like the?
To check their feet.
Yeah.
Yeah, the little
Their
fiber
toes.
things, you
Yeah.
can use those. Don't use needles. Don't use
No,
needles.
it's like a little thing,
Or
you
the-
just roll it on it
Yeah,
and it.
but I've seen people actually
But not
use
the
like
metal
a fine
ones. It's
needle.
like,
Don't do
no,
that.
no,
That's
no.
mean.
That's hateful.
What were you gonna say?
I said reflexes.
Okay.
I don't know if that was.
Reflexes are different because remember, reflexes don't have to travel to the brain and back. They just travel to the spinal cord, loop around, and come right back down. So reflexes don't affect that. What you can pinch them. Where would you pinch them? You can pinch their nail beds. Take your pencil. Do this real light. Take your pencil and just push it on your nail bed. Nope, this way. Take your pencil like this. Lay it on your nail bed and push down on it.
Ow.
See how much pressure it takes to cause pain. So if you do that to someone who you think is comatose and they react to it, they're reacting to pain. They'll pull their hand away. Okay. 3. Let's look at 3. 3 is decortating positioning. They bring everything in, their toes point out. Okay? 2, everything's just out. Totally relaxed. The worst one is number 1, no response at all. Okay? So the lower my number, the worse the condition of my patient. No response at all. Pupils. You're going to check their pupils. What am I checking for when I'm checking pupils?
Perla.
What does that mean?
Pupils equal round reactive light
Okay.
combination.
How am I going to do it? So if I come up to Terry right now with a light, is that going to work?
No.
It might work a little bit. What do I want to do in my patient's room?
Then
I want to dim the lights down.
so you can see the.
Do I want to get out my mega flashlight? No, you don't need to shine your massive deer spotting headlight on them. You can just use a little pin light and see if their eyes constrict, okay? Think about your patient. This is part of your assessment, but is this part of the Glasgow Coma scale? It's not. Your Glasgow Coma scale is this. But this is part of my assessment, because when I call the doctor and I say, I've got this patient who has a Glasgow Coma scale of 11, he's going to say, what are their pupils doing? So it's just another piece that he needs, but it is not considered part of the Glasgow Coma scale. So we are going to, I want each table to take one of these little scenarios. So you two are going to work together, each table, 2 people working together. And I want you to assess your little patient here. Pass those back. Take one and pass them back. And some of them are duplicates because, I only had 20 and I was too tired last night to think some more. So I want you to take your patient and I want you to assess your patient. Now listen, when you're doing your Glasgow Coma scale, I don't want you to just tell me it's an 11. I want you to say they scored an 11, verbal response was a 3, motor response was, and eye opening was. Because those are important pieces of information. So you work in pairs and assess your patient real quick.
Can you put this scale back?
Oh yeah, I'm sorry.
Thank you.
No.
And I'm not going to give you a question on the test without giving you the scale. So don't memorize it.
He opens his eyes, tells you to play, pushes your hand. So you don't even speak to him, you touch him first. Because speaking. He tells us to go away. So is that a 3? Would you put that there in appropriate words?
5. He's oriented. Oh no, he's definitely not freaking oriented. He's
No, that's what I said, inappropriate words. Is that what you tell him? Go away.
probably 4 confused. And he was deflection in response to pain, so that's a 3. 10.
Well, she said localizes is the one where he would push her hand. 4 is where he would pull his hand back. Reflection is what his whole body.
Oh, yeah.
Okay, so it's going to be 5. 3, 4, and 5. Yeah.
Good.
That's going to be fun.
You go, girl. Yeah, that's what fun.
Okay, so you can see, since we're taking like a few minutes to do this, that this is kind of important.
Yes.
Okay? And you're going to see this on a test in level 2, level 3, and level 4. So it's not good enough to just say, well, yeah, we'll just do the Glasgow Coma scale. No, you need to know what that is and how to assess your patient. So we're going to just do these real quick. I know that there might be 2 of each number out there somewhere. So who has number 1? Okay. Can you read it to us and then tell us how you assess your patient?
Client fell while rock climbing. You apply a deep sternal rub and he extends his arms and legs but shows no other response. What's his GCS? We gave him a 4.
Okay. So eye opening was a 1.
Yep.
No verbal response.
Yep.
And he was in this position right here. Yep. Okay. So they gave him a 4. Okay. Number 2. What is number 2?
What is the Glasgow Coma scale for a client who is pulseless and apnea. We gave them a 3 because they're probably dead.
They're probably dead. They get 3 still. Yay, everybody gets 3. Okay, number 3. Who has number 3?
A 73-year-old man looks at you and speaks to him. When you ask him the date, he replies blue. You note left-sided weakness when he grips your fingers. What is his hospital response? This is 12. Because when you speak to him, he opens, and then he says inappropriate words, and he said blue. And then he said that he obeyed commands because if he's gripping our fingers, we asked him to grip our fingers to see anything.
Okay, so their scenario had weakness in it. Is weakness a part of this? No, that's another skill you're going to learn in level 3. He obeyed their commands. He tried to do what they wanted him to do. So it doesn't matter that his grip was weak. He tried to do it. So he's mentally intact to do what they wanted him to do. Okay? So yes, that's important. So we gave that person a 12. Okay, number 4. Anybody have 4? Okay, I'll read it to you. The trauma patient moans, bends his arms toward his chest, and points his toes out when you start an IV. What would you give him? He moans, bends his arms toward his chest, and points his toes out when you're starting the IV.
So you get 1, 2, and
Well, he's moaning. So is he saying any words?
no.
So what would you give him for verbal?
2.
Okay. It doesn't say in here if he opens his
1,
eyes
2,
or
and
not.
3.
So he get a 1 at least.
So 1. And what did he do motor response wise?
3.
3. So he got a 6. Okay, who has number 5?
We do a 4-year-old male who fell from the top of a
You have
jungle
5
gym.
too. Go ahead.
A jungle gym is awake and neurologically intact in all 4 extremities. When you ask what happened, he tells you he fell on the playground and then goes on tell you he all about his dog. What is his Glasgow Coma scale? Give him a 15.
Okay, why'd you give him 15?
Because he fell at the gym, he's awake and he's intact in all 4 extremities. And when you ask what happened, he tells you he fell on the playground and then tells you about his dog, but a 4-year-old's going to tell you about that.
Right, you had to look at his age. He's 4 years old, so he's off and running on another thing before you even are finished assessing him. So just because he's talking about his dog doesn't mean he's disoriented. He's not. He knew what happened. Okay, what about number 6? Okay,
You are assessing a 20-year-old male speculative overdose. He's staring off into space, writhing about it. You start his IV, he cries out incomprehensible. It is not clear, like, what is his Glasgow? I got a 7.
okay. You all agree with that?
Yeah, we got a 7 too.
Okay. Your transport, okay, who is number 7?
You're transporting an intoxicated client. When you attempt to insert a nasal airway, he opens his eyes, slaps your hand away, curses at you, and sits up. When you stop, he lays back down on the stretcher and is calm and quiet. We gave a 12 for 5 localizes to pain, 2 opens eye to pain, and 5 oriented because he sat up and cussed us out.
Okay, yeah, he could have a 4 or 5 there depending on how you interpret it. So let me just tell you something. I got a text one time from somebody that said, my patient is cursing at me. Is that inappropriate language? Well, that may be inappropriate language. Depending on the situation, it may not have been inappropriate language on the Glasgow Coma scale. You get it? I mean, she was actually in the hospital, and she was on another level and texted me to ask me that. Just because they're cursing at you, that might be totally appropriate for the situation and for that person. So you just kind of have to look at what's going on. That patient was intoxicated, so of course he's going to curse you out. Okay, number 8.
A 75-year-old man rubs his chest and tells you he's having chest pain. He tells you he needs to be admitted to the hospital and to assist him to the gurney. I gave him I gave him 15.
Okay, he knows what's going on. Matt was able to get him on the gurney. He was able to follow commands. Okay, number 9.
A man is found on the ground outside a homeless shelter. When you give him a stone rug, he opens his eyes, tells you to go away, and pushes your hand away. You gave him a 14.
say anywhere that they opened his eyes. though,
What's
does
that?
Yeah, he opens his
Oh,
eyes.
does it?
Yeah.
Okay.
Yeah.
Okay, number 10.
A possible overdose client looks around with an unfocused gaze. She mumbles when you ask her questions and pulls away from painful stimuli. We gave her a 10
Okay.
because she's looking around with a gaze, so a 4 for that. And then her mumbling, you don't really know what she's saying, so we gave her a 2. And then withdrawals from pain, 4.
Okay, where did you get she withdraws from pain?
She pulls away from painful stimuli.
Okay, yeah, I was reading that. I'm like, she's walking around. Okay. Okay, who has number 11? Okay.
An elderly female in a nursing home is walking around and greets you when you get in. Her speech is clear, but her eyes are confused. What is her? We gave her a 14 because her eyes open. So 4. Her speech is confused as a 4. We didn't give her any painful stimuli, but she's walking around. So
Okay. Number 12.